Dr. Erica Sutton is a graduate of Indiana University Bloomington with a medical degree from the Johns Hopkins School of Medicine. She completed her surgical training at the University of Maryland School of Medicine. In Louisville, she served as chief of the Department of Surgery at Jewish Hospital, as well as a tenured associate professor in the Hiram C. Polk Department of Surgery at the University of Louisville School of Medicine. But most important, Dr. Sutton was founder and president of Surgery on Sunday Louisville, then later Lexington, where she marshaled medical professionals and others to volunteer their Sundays to provide free surgeries to people who are uninsured or underinsured. I personally witnessed the work of more than 500 volunteers who provided life-saving surgeries to more than 800 people free of charge. Dr. Sutton just last year was appointed to a newly created role at Morehouse School of Medicine in Atlanta, Georgia. Now, Morehouse is one of the nation's finest HBCUs, that's historically Black colleges and universities. She was appointed as the school's first Associate Dean for Academic Programs and Affiliations. And again, in full disclosure, when she is in Louisville, she is my neighbor. She joins us from Atlanta today, the home of the Centers for Disease Control. Please welcome Dr. Erica Sutton.
Thank you so much. Thank you for the opportunity to be here. I'm going to jump into my talk so that we have time for questions at the end. I'm going to share screen. So I want to talk a little bit about today the disparities that we've seen in COVID-19. Really, its impact, its health inequity, and who it's affecting in the Southeast region. I'm going to talk a little bit then about its impact on uninsured and community health centers, and specifically in cancer screenings. So I have no financial disclosures relevant to this presentation. So this is actual mood footage of me, okay, March 16th, first day of work from home. I was Zoom meeting and I was making school lunches and had written things in the planner and had plenty of toilet paper in the house. And so I truly felt like, 2 weeks from now, when this thing blows over and they reopen schools, I will have shown what a phenomenal woman, mother, surgeon, and administrator that I could be. Okay, this is equal footage roughly a month later when we learned that Georgia schools were not going to be open until August. And the pictures of when we saw that we were going to begin virtual are even more gory, not fit for public display. There was a lot that happened in our country and in our nation's health, even in that 1 month. And so we're going to talk a little bit about that and about where we are today. By the time we're done, we're going to be able to recognize communities that are most impacted, even disproportionately impacted by SARS-CoV-2 or COVID-19. And I think this is the most important part of this talk for me, which is helping others find sources of accurate and reliable information for disparity data specifically, and then discuss some strategies for recover and future health equity, which Morehouse School of Medicine will play a part. So this was an article from the New York Times on March 30th. And it first recognized a county in Georgia, Daughtry County, that had registered at that time 24 deaths. And it was far more than any other county in the state of Georgia, and 6 more were under investigation. And 2 weeks into what was a declared emergency, this was remarkable. And it was noted at that time that 90% of the people who died were African American. And so that was really sort of an early tell that there were disparities in who was affected by COVID-19. It's believed that there was a super spreading event similar to a conference in Boston held by Biogen, a 40th birthday party in Westport, Connecticut, that the funeral of one resident in Albany, Georgia on February 29th was considered a super spreading event. Now, I'll tell you that I was in Albany, Georgia on February 29th at a funeral, not this person's funeral. And so I think that it's hard to pinpoint one event although there is such a thing as a super spreading event epidemiologically. But keep in mind that there were people in hotels and restaurants and interacting from many different parts of the state and potentially neighboring states that likely came together in this rural county in Southwest Georgia that is really 40 miles from, even any interstate, to create what was a super spreading event. I truly think that and uncustomarily, my family didn't engage in any of the socializing activities such as the repast. And I think that, potentially protected us because we hadn't been ill there. So what we learned in that 1 month time is that COVID-19 is a health inequity modifier, and that populations that are disproportionately affected have proven to be African Americans, nursing home residents, essential workers who are more likely to be ethnic minorities and are less likely to be able to social distance. And I'll show you some data about how that was proven. And those with chronic conditions, diabetes, asthma, heart disease, and we believe inmates for similar reasons of social distancing and chronic health conditions. So we'll talk more about sources. This is from APM Research Laboratories, which I think is a great site for identifying COVID data by ethnicity. It's really one of the better ones that I have found. And this talks about the COVID-19 deaths per 100,000 people through last Monday. I can tell you that I've been on this site several times, and 3 months ago, we had no data on indigenous populations. The yellow bar was nil because we simply did not know. And so one of the things that has improved is the tracking and reporting. So right now, there are only 3 states that do not report COVID-19 data by ethnicity. That's North Dakota, West Virginia, and Hawaii. All other states and US territories are contributing to this data reporting. And so we are able to see that as more states began to report that Black African Americans were most disproportionately affected with just under 100 deaths per 100,000 people, followed by indigenous populations. I want to point out that we also didn't have accurate data for Asian populations early on, as early as 2-3 months in. And so we've seen an increase in what has been the prevalence. It is still known to be lower than that for white Americans, but we certainly have better data now about this population. Pacific Islander is also a bar that is new in terms of reporting, and hopefully as Hawaii does begin to report or make a decision about reporting, we will see accurate data there. I wanted to pull up some things about our region. This is not to exclude North Carolina, South Carolina, and Virginia, but I thought I'd pull the states that both are near proximal to Louisville and then, kind of in the news right now. And this was just age-adjusted mortality rates through last Monday for the different states. And I think that it's important for everyone to see where Kentucky stacks up. Kentucky is doing, rather well, relatively well compared to other Southeast regions. And that's thought to be in part due to the low density of population in most of the state. And so you can see that Kentucky fares very well there. So to speak a little bit more about age adjusting, what does the age adjusting do? Age adjusting adjusts for what would be expected deaths. I want to report that the COVID-related deaths in 6 months, okay, today is September 17th, is a little over 195,000 Americans. And I think that it's sobering to acknowledge that number and to think about nearly 200,000 Americans, roughly 900 a day, that are still dying from COVID-19 as we are looking at what does it look like to reopen schools, reopen businesses. The death toll increases for this disease, and that's a significant number of people that we have lost. So when we talk about age adjusted, we're looking at that because, well, in 6 months, some Americans may have died of other expected causes. And so age adjusting, and in this case, the indirect age adjustment method was used. I had to look that up. It was used to account for what are the expected numbers of deaths. And so when you look at just what's attributed to COVID-19, you can see that those numbers have gone up across the board for all ethnicities, meaning there are more deaths than were expected for this ethnicity due to COVID-19. So I liked this demonstration of the point that affluent Americans are more able to socially distance. This was tracking cell phone data, so where your cell phone pinged off of the nearest tower for the 10% wealthiest Americans in blue and the 10% poorest Americans in orange. And you can see that really the shift from wealthy Americans being more mobile to traveling less, sheltering in place more. And then after several shelter in place orders and restrictions came to play, how mobility for the wealthiest Americans dropped, but remained high for the 10% poorest Americans. And that is really thought to be a demonstration of their representation as essential workers and needing to be mobile and being less able to socially distance. I did want to show this data because we talk about age, and that under age 45, and I turned 45 a couple months ago, 6 weeks ago, under age 45, we still see that death rates are pretty low, but that they are tenfold for 45 to 54, and they double again in the next decade, and then again double for 65 to 74, and see that they're triple to almost quadruple that for age over 75. And it's important that if you're under the age of 45, if you're under the age of 54, it's yes, yourself that you're protecting, but it's Americans in this category that you're primarily protecting. So a word about the comorbid conditions, this is to really demonstrate and show the prevalence of comorbid conditions by ethnicity. And so I wanted to point out here that American Indians and Alaskan Natives really do lead this graph as being identified as having asthma, diabetes, or heart disease in greater proportions, even greater than African Americans, which are generally second highest in most data that we look at. And so again, this has been new data. This has been a new look at how ethnic populations are affected overall, not just by COVID-19, but by health conditions that have contributed. This is from the University of Chicago, and I'll show you them as a source. But this was really trying to capture Native American and tribal communities' incident rate and the cases of COVID-19. And you can see that per 100,000, those are quite high in counties in which there were high percentages of Native American population. So that's almost a 1% prevalence of the disease itself for New Mexico, areas of New Mexico. And these are areas that should be, by nature of low population density, dispersed, but because these communities are tightly clustered, we think that is why we saw such high numbers there. So where to look for accurate information, and this is really what I think is one of the valuable things that we'll share today. This is the APM Research Lab. I've put the website there, and we'll certainly share the slides. But this allows you to look by state, by race, by ethnicity. It really groups out every ethnicity, COVID-19 statistics for white Americans, Black Americans, Latino Americans, Pacific Islanders, Asians, and really summarizes the data for each ethnic group there. So I think they've done a really good job. I really perceived a lack of bias in their data presentation. And so often we'll direct people who are looking for a source of disparity data to APM Research Laboratory website. I think the New York Times has been a consistent source of good and interesting information. The previous and the next data source are often used by the New York Times, but I feel like unless you are comfortable analyzing data and reviewing it, then you might not comprehend as easily some of the primary data that you'll get on those two websites. So I do recommend the New York Times as an approachable source of data for statistics related to COVID-19. This is the other site that I thought that I considered as leading the way for unbiased and detailed information. And you can pull information specifically for your county from the University of Chicago site, the Center for Spatial Data Science. Now, I can tell you that on this site, I can nerd out for an hour. just the way that you can parse the data, look at the data, look at Kentucky, look at Georgia, check out the red, zoom in, look for counties. And so I wanted to show you this, this view, because this is actually the county view from Monday. So that, you could see the granular level of data that you can pull out there. If you're looking for, let's say you wanted to follow up on data for a county in Arizona or New Mexico or Jefferson County or Daughtry County in Georgia, then you're able to look at this site and find very specific up-to-date information that has been reported. So that's University of Chicago. I find that Kaiser Family Foundation consistently over many years has good data on the health care and health status of Americans. If you dig deeply, you'll perceive some bias in the site, but I think that if you look at the reported numbers, you're going to find a lot of very accurate and very useful information on not just COVID-19, but a lot of health conditions and health status, underinsured Americans and data for them, cancer rates can be found on this site. So I usually will check Kaiser Family Foundation and even just compare that data to data that I find in other sources. The last two are some of my favorites to share, like with my parents. The World Health Organization, so that they get a sense of how the United States is positioned globally and what's happening on a worldwide front with COVID-19, as well as reporting and why they see some of the coverage and restrictions that Americans are experiencing in travel. And then lastly, of course, near and dear to those of us here in Atlanta is the CDC. And so I also recommend, I think I don't check the cdc.gov site daily at this point, but for many weeks, it was part of, my morning check-in on information to learn what the CDC was saying and was recommending. And so this is also another site that I recommend many Americans become familiar with and learn to look for their information. So this is this has really been an inspirational quote for me during this pandemic. As you know, part of what I'm doing here is administrating a medical school through this pandemic. And so I like the idea that whatever we build on the other side, in part because that brings hope of the other side, that it has to be better than what we had before. And I hear so often in so many people who are trying to get back to where we were, but I don't believe in that reality. I believe that we are going to get to some place that we hadn't been before, and that it has to be better than what we had. I'm going to talk a little bit about the impact of COVID-19 to community health centers in the United States, and I'll give specific examples as it relates to Surgery on Sunday Louisville. So annually, community health centers serve, really now the count is over 30 million people per year. Updated numbers say that's 30 million people in this country served by free health centers. 91% are identifiably low income. and recognized at often below the poverty level. 63% of people seeking care in community health centers are racial or ethnic minorities. And so I point this out because if there is an impact that you're looking to have in racial or ethnic minorities or in people who are low income or do not have access to health care, this is the place that I would recommend we all begin. We all begin with our nation's community health centers. Federally qualified health centers is another term that you will often see here. So I wanted to bring this statistic. There's not an updated statistic to the ones that were produced in May, but I wanted to bring up what the community health centers were experiencing in terms of COVID-19 testing. And they found that they had a 28% rate of testing positive, which was double the already alarming national rate. It was saying that of the patients they were seeing, that roughly 1/3 were testing positive. And this is really before the surge that we saw in July, where we saw more people who were asymptomatic or mildly symptomatic testing positive. And so we don't have updated data from the community health centers during that time. And part of the reason we don't have that data is another part of the unfortunate story. This was the percentage of health centers that were closed due to the coronavirus at a time when these populations really kind of needed them most. You could see the 13 states had 25 to 73% of their health centers closed. And large numbers. So if you look at just the top 3 categories, that encompasses over half. The top 2 categories encompass over half of the states. So this is a significant loss in terms of access to healthcare in a population that was already marginalized. I would say that Surgery on Sunday, who is reliant on our federally qualified health centers as care points and medical homes for our patients, we were also relatively dormant at that time. I'm also happy to say that we have since resumed clinical operations. We saw patients last month. We are seeing patients this month. And we are really setting up some of our first Georgia patients to be seen here this month. So it's exciting to return. What did we do to be better on the other side? Well, we used that time to really establish an electronic medical record so that we could track patients more easily, that we could leave documentation that is more easily shared with other health providers. And right away, we have gotten back to something that is core to our mission, which is helping patients access health care. So among our first patients seen in August, we were able to get health insurance for one of those patients, which was one of the 2 that we saw. So we're back. We feel like we're a little bit better, but we also are, moving more slowly, as are all of the federally qualified health centers in the country as they reopen. The challenges to reopening these critical access points are financial stability. There's a precipitous decline in volume that does support the financial position of the organizations and the workforce. Closures and risk of, delivering healthcare has challenged what was already an under-resourced workforce. And so those are things to keep in mind when you're entering the space or you're considering how access has been affected and how health access can be improved. So I'm going to say a little bit, just a few slides about cancer screening and colon cancer screening, because as you know, our mission at Surgery on Sunday started here in colon cancer screening, and it's where we've started again in re-entering the clinical space. And so what we know is that just adjusted for 2015, this is pre-pandemic, there are persistent cancer screening disparities among insured and uninsured, except there has been an improvement in colorectal cancer screening. And I could not be prouder of people in the fight against colon and rectal cancer screening. It has taken everyone, it has taken multiple national organizations and efforts, and it made the loss of Chadwick Boseman feel personal, I think, to a lot of us, because Black males are a targeted population in whom we're trying to improve the screening and the messaging for on-time cancer screening. Early onset cancer continues to rise, and so on-time screening is very important, and it's a message you will hear preached particularly well in the state of Kentucky. Um, on my screen, all of our lovely faces are covering the end of that graph. But what this is to show you is that cancer screenings in the US during the time of the pandemic have dropped precipitously. And the top is breast cancer, the middle is colon cancer, and the bottom is cervical cancer screenings. And this we have to address with some element of urgency, because we are seeing more people return to the clinical space for their routine health care, but it has created more challenges and an overload of work for an already, I think, challenged physician workforce. And so we have to get these screenings back up and in place so that we are not dealing with downstream late presentations of cancers. So what must we do? What must we do during these times? For colon cancer screening, I say we have to get back to screening people. There are no additional recommendations that have been placed for processing, handling, or storage of endoscopic equipment. In all clinical spaces, we're going to wear personal protective equipment. We're going to ensure our patient comfort and our patients' comfort with our safety measures. We have spatial distancing protocols and flexible schedules in place for staff and for patients, and then simply clean the rooms thoroughly in between care. And this is an important point that I think it continues to be a relevant message, which is that we all have to attend to staying healthy mentally as we forge through new times and new conditions. I tell people, if you make me a promise for something a month from now, I hear you, but I am not counting on what the world will be like that we're living in a month from now, because we all know that we're getting new information almost every 48 hours that dictates the way in which we live and we work. And what I'm asking everyone here is that we look at our standards and how we care for each other. I want to thank you again for the opportunity to speak to your group. It's been very meaningful to me. I love all of my connections with Louisville and do work to maintain those. And so I appreciate the opportunity to speak to this group today.
Thank you so much, Dr. Sutton. And you mentioned the surgery. So the last couple of months, were they in Louisville? Are we still continuing surgery on Sunday in Louisville?
Yes. Well, that's why I think it was very important, both with me relocating to Georgia and the pandemic, for that care to begin in Louisville and to continue to be a resource for the city of Louisville. So our clinic last month was in Louisville, and our clinic this month is also in Louisville. Yes, ma'am.
Where this month? When is it?
It's 1406 Washington, the Family Community Health Center, and the date is this the third Thursday. This is likely the third Thursday of the month, so it should be this afternoon.
Wow. Okay. Do you know how many patients you have signed up for this afternoon?
This afternoon, I think we're seeing 3 patients. We've tried to keep our volumes low and related to cancer screening, and particularly because once we screen someone, we tend to get people who are highly symptomatic and who need follow-up procedures. So 100% of the people that we saw in August needed a follow-up procedure, which means that we have to, make sure they get scheduled with a provider who's willing to donate their services and a facility that's willing to donate their services. And we've been fortunate and able to do that. And so I think our largest clinics would sometimes be around 10, and we are slowly phasing back to that number.
And when you had those clinics, I want to make sure that everybody understands, when you would have those surgeries on Sunday, there would be typically at a hospital, and you would rotate, Jewish University Baptist. And if you found, say, a lesion or whatever, it was removed at the time.
Yeah.
So it was not only screening, but treatment as well for those patients who presented that Sunday for free.
Yeah, so let me represent that we see people in clinic because we think that's part of establishing continuity for them. But there's also the follow through to their procedure. And that has not been limited to colon cancer screening. We have really taken care of a lot of conditions related to cancer, hernias, gallbladders, hand surgery, plastic surgery, facial plastics and pediatrics, orthopedic surgery. We really have worked to take care of whatever it is the community in Louisville needs to be healthy as it relates to surgery. Dr. Frank Burns does eye surgeries for us as part of his commitment to caring for Louisville. And so there's not a limit to what we have and will take care of. If it's surgical and it is needed and someone who doesn't have access, that's what we do.
Awesome. Okay, we have some questions for you. It was wonderful. Um, let's talk about the increase in enrollment of people in health insurance and why the gap of people that don't have care. Why? Is it because it's too expensive, even though they have insurance, due to high deductibles?
Yeah, so we found that there was almost a terrifying gap because now once you could access the health exchanges, and Kentucky led the country in making that available to its residents, people who were not receiving health care, it's because they couldn't afford to participate in those exchanges, or they were not eligible. And so one of the early meetings that we had as Leadership of Surgery on Sunday was, great, we have Kentucky exchanges. Do you need us in this space? And it was absolutely, we still need you in this space. I'd point out that in Louisville in particular, our one of our primary industries, the horse racing industry, is supported by people who do not have a social security number, and we call them unregistered residents. And so that means that people who live and contribute to the community there in Louisville do not have access to simple evaluation if they have a hernia, or if they're having gallbladder attacks, colon cancer screenings, breast cancer screenings, cervical cancer screenings. And so the initial patient population in Louisville was 76% Spanish speaking as their primary language, really owing to the industries that we have present there.
Mm-hmm.
The gap for them was made bigger.
Do you have a recommendation on how to communicate with people that it's safe to go to healthcare facilities?
I'm going to give this recommendation, not just for healthcare facilities, but really for any travel, for any time you're going to choose to leave your home. Take a moment and look for what are their practices. What are their accommodations, their requirements for social distancing, for mask usage. And then when I go to a healthcare facility, I'll be very honest, before I walk in the door, I'm looking for those standards that make me feel comfortable. Now, I recognize that every American may have a different standard for what makes them feel comfortable. But I do like to see that the standards that make me feel comfortable, mask wearing, social distancing, and the accessibility of hand washing or hand sanitizing is in place before I engage. And then, as when I leave, I have a personal practice that also involves hand sanitation. Do not put things into your mouth, meaning don't eat finger foods on your way out of the grocery store. And those are practices that can make you safe. I found that most healthcare facilities, of course, by nature of being a healthcare facility, have had to have these things in place for the safety of patients and do monitor their environment.
Can making telehealth available to low income permanently improve outcomes and provide better prevention? So the legal issues of telehealth were relaxed during the pandemic. Should those changes be made permanent?
I think that they will be made permanent. You always have to consider access anytime you add technology to a platform, but we have found that most people have access to smartphones, and allowing for different telehealth platforms that can be accessed via a mobile device is making that more accessible. We also found that it's really been very much enjoyed by older Americans who otherwise were just at risk for influenza or other, communicable disease by going. We found that there is absolute permanence in behavioral health. And so behavioral health services have largely gone telehealth and are unlikely to revert back to anywhere near the pre-pandemic rates. I mean, you'll see that behavioral health services are now at least 80%, and that's every system that I've looked in. They're at least 80% telehealth. And I think this is being enjoyed by providers and patients.
Does vitamin D deficiency be a factor in the COVID disparities? Is there validated or has it been studied in any detail?
I looked this up because, I really wanted to know what was the data around vitamin D, magnesium, zinc, these things that I saw. And there was actual, there's some studies, and I'll look through my files for those folders and send them to you, that suggested that ensuring that you have vitamin D, and that magnesium and zinc have also been impactful in preventing infection with SARS-CoV-2.
So the CDC is your neighbor. They're in Atlanta, and you mentioned checking the website. Okay, in the last couple of days, there's been just confusing information for Americans. We just don't know what to think. Dr. Redfield is saying one thing about vaccines.
Yeah.
Our leadership is saying something else. Dr. Redfield is talking about wearing masks as opposed to a vaccine. So, how, help us understand all this.
You have to understand that I live in the city. I mean, I live in Atlanta. So at one point, Governor Kemp, who has done some really outstanding things for Georgians, was saying, we're open, it's May 1, go out, long live the economy. And our mayor, Keisha Lance Bottom, was saying, stay in your house, lock the doors, it's not safe out there. And so I also think that here in Atlanta, we had to figure our way in light of really conflicting beliefs among the leadership. What I would recommend when you're finding conflicting data, it's really why I think one of the most important pieces of the talk was where to find accurate and reliable information for yourself, is you're going to have to make a set of standards for yourself and for your family, and even in some cases for your community. So my kids are part of a learning pod, as I said earlier, and that means before we travel to Kentucky, I wanted to let the learning pod know that we were going to Kentucky and what we expected our exposure to be while we were there, so that they were aware, and that when we came back to learning pod, this would be kind of the expected exposure. And then while we were traveling, to maintain social distancing and masking and all of those things. I think it's critical. I mean, we were coming from Georgia, a national hotspot, to Kentucky, not a hotspot. And so I think it's also important to have conversations. So I recommend that in the space of a lot of conflicting information, data, and beliefs, that you analyze those for yourself. Choose the sources that you trust, and you come up with what it is going to take to keep your family safe. What I reiterate with my family, that though I believe there's a lot of science that we do not know about this virus, we do not know much about asymptomatic individuals who are carriers. We do not know much about reinfection rates. There's a lot of science that would be very helpful that we don't have. But what I do have is nearly 200,000 Americans who died from COVID-19. And I cannot argue with the impact of that significant loss of life and the impact to families. It is hard to find an American who does not know someone or who has directly lost someone. And so at the end of the day, I have to use those 200,000 Americans to guide me and my family.
You are on a big college campus and on a cluster of college campuses. And I'm sure we have members who have either kids or grandkids who are college age, thinking of going in person. What are you doing at Morehouse? And how do you have a virtual medical school? I mean, how does that work?
Virtual medical school is a struggle. But so I would say that our partners in the AUC are Spelman College, Morehouse College, Clark Atlanta College, and you should know they're virtual. I've been meeting with some of those students, and they are at their respective homes around the country. And I do think that was an important decision by the AUC, because we are a cluster of African Americans in Atlanta, in Georgia. And so I do think that while it is definitely challenging for those students, and we do a lot of coaching on their emotional well-being and their academic study habits, that was an important decision for our 18 to 22-year-old population. Their judgment, we know, is not fully mature or developed until sometime after 21 years old. And we see that around the country. We see that in what's happening on college campuses around the country. So I am grateful that at the Atlanta University Center schools, we've made the decision to keep our undergraduate students at home. The fact is that we just cannot teach people to be doctors from their homes.
Right. Yeah.
And so we have, where possible, put everything online. and done everything virtually. So our first year students are still all virtual. They will be coming to campus for the first time on Friday. We have all been getting our third and fourth rounds of COVID testing this week, institutionally sponsored, paid for, organized. And so we moved from periodic testing, and so we are now moving to weekly testing, and perhaps as high as twice weekly testing, but my nose's sake, I pray it is not more than once per week that we're doing testing. That has allowed us to maintain a hybrid environment in which, for example, my work schedule, I'm talking to you from home today because my work schedule is Monday, Wednesday. I go to work Monday, Wednesday, every other Friday. The other half of our faculty is Tuesday, Thursday, and then the every other Fridays. We have all put together different strategies for our children in our homes, but that has allowed us to maintain the presence that we need to teach the in-person components of doctoring that we just can't simulate through the screen.
Like anatomy.
Yes.
Anyway, thank you so much, Dr. Sutton, and I'll see you soon. Julie, turn it over to you.
Dr. Sutton, thank you so much for your informative and inspiring presentation. We really appreciate your time and all that you do. Next week, we're looking forward to having the Filson Historical Society's Jim Holberg, who's curator of collections, who will be with us, and he'll be talking about presidential elections. Please join us early at 11:45. Rotarian Julie Skoski is going to share a little bit more about what's happening at the Filson. So it'll be a great conversation with Julie, and I know you'll want to be with us 11:45 next week. So call in early. And I just want to thank everyone for being with us, for just all that you represent and all that you do in the community, and for serving as Rotarians every day. And with that, we're adjourned.